On behalf of the LAM Foundation, it is my pleasure to welcome you all to the first of 3 educational sessions we are offering as part of our LAMposium in Your Living Room series this fall. My name is Charlene Dunn. I am the Patient Outreach Coordinator for the Foundation, and I'd like to thank you for joining us as we bring LAMposium into your living rooms. This series evolved from the speaker schedule we had prepared for LAMposium last spring, and I would encourage you to learn more about this series or to review recordings of the 2 sessions that we offered in May and in June. Be sure to check out our LAMposium in Your Living Room landing page on the Foundation's website. I would also like to thank NDRI and the Data Foundation for its support of this educational series. We couldn't make this happen without our dedicated sponsors. Just a couple of quick housekeeping items before I turn this over to our moderator this evening. First, as you've noticed, we will keep the microphones and the chat box muted throughout Dr. Kotloff's presentation this evening. We will then later open the chat box for the question and answer session. Once the chat box is open, you'll have the opportunity to type your question into the chat box, and Dr. Kotloff, our moderator, will then read our questions to Dr. Kotloff, and we will try to field as many of your questions this evening as possible. And then following the Q&A, we will move into the patient and family group discussion. And we hope that you can stay on for that this evening. It's a wonderful opportunity to engage with our fellow LAM sisters in our community. And now it is my pleasure to introduce Madeline Nolan, our moderator this evening. Madeline has been our LAM liaison in Region 1, which covers our New England states, since the inception of our LAMposium, our liaison network, although she did manage to take a few months off following her lung transplant. In short, Madeline has been engaged with and supported the LAM Foundation in more ways than I could possibly name here this evening. If I had to choose just 3 words, I thought a lot about this, that would describe Madeline for you, for those of you who haven't yet had the opportunity to meet her, I would offer these 3 words. Madeline is passionate, and I'm talking UConn basketball and the LAM Foundation here. Madeline is incredibly energetic, and I'm talking a high school teacher for over 30 years, as well as hosting countless educational meetings and fundraisers for the foundation right alongside her work. And Madeline has a huge heart, which I guess brings me to 4 words, but I'm talking family here, including her adorable 4-year-old grand twins, as well as her beautiful family of LAM sisters. Madeline, it is a pleasure to have you with us. Thank you for hosting this evening, and I'll turn it over to you here.
Thank you, Char. Welcome, everybody. We are really so happy that you all could join us tonight for Dr. Kotloff's presentation. We're going to learn so much more about a topic that may be very new to some of you who are on tonight, and others have been around a long time, and we've seen the inception and the growth and the benefits that have come from Rapamycin. So we are very excited to share this night with you. We want to start out our session by spotlighting a LAM patient, Sally Nagel. I'm excited to introduce you to Sally. She has been an active member of our LAM community for over 20 years. If you've attended LAMposium or spent any time going by the fundraising table, you might recognize her. While 20 years may seem like a very long time, Sally has actually had symptoms of LAM since 1975. Her diagnosis followed in 1981 when she was just 31. She made a connection with Sue Burns and the LAM Foundation in the late 1990s. In 2000, Sally attended her first LAMposium in Cincinnati, face-to-face, side-by-side, unlike tonight. But we're glad we're together here. As she expressed it, when she first met Sue and Frank, she says, "We hit it off." While working full-time, Sally was still able to participate in numerous research studies, surveys, projects, clinical trials, all to advance LAM research. Regular visits to the National Institutes of Health connected her with other LAM patients, allowing her to build strong, supportive, and long-lasting relationships. Her participation in online LAM groups over the years has provided much wisdom and support for new patients. Sally's most special contribution was to be honored by Dr. Frank McCormick as the first patient enrolled in the MILES trial. She had volunteered for the initial CAST trial. However, she did not meet the criteria. That was disappointing for a person who wanted to do all she could to help. We're already in 2006 here, another opportunity presented itself, and Sally traveled to Cincinnati to be patient number 1 in the MILES trial. We thank you, Sally, and all those that followed her. Your participation has made a huge difference in the lives of patients who benefit from sirolimus today. In addition to her LAM community activities, she loves to exercise and work out. It's a regular part of her life. She now has retired, so she also has time for other things, like making blankets, taking drives in the country, reading, catching up on some TV series, and enjoying Marvel movies. And oh yeah, she says she likes to spend money. Sally's encouraging words to us are, live life and quit worrying about the small stuff. Think of the possibilities ahead of you and volunteer. Sally, we are so grateful for your commitment to help find this treatment and a cure for LAM. Being proactive for so many years is amazing. Your example of offering your time, your energy, your support is inspiring. Like so many LAM patients since the early days of research to now, we figure out ways to be part of the solution. We love you, Sally, and thank you so much. So now it's time to hear about our presenter, Dr. Kotloff. We're going to hold on a minute while I make sure I'm right. Dr. Kotloff specializes in pulmonary medicine with expertise in diagnosing and treating patients with lymphangiomyomatosis and other cystic lung diseases. He also maintains an active interest in general pulmonary medicine, and in particular, evaluating patients with complex pulmonary disorders. Dr. Kotloff received his medical degree from Yale University School of Medicine. You know, you were right down the street from me for a long time, and I didn't know it. He completed a residency in internal medicine at Temple University Hospital and a fellowship in pulmonary and critical care medicine at the Hospital of the University of Pennsylvania. He was one of the founding members of the Penn Lung Transplant Program. After 23 years on faculty at Penn, he left to become chairman of the Department of Pulmonary Medicine at Cleveland Clinic and recently rejoined Penn faculty as director of the Heron Lung Center. Dr. Kotloff has authored over 120 peer-reviewed articles, reviews, and book chapters, and has edited or co-edited 6 books. He currently serves as a senior deputy editor for the Annals of the American Thoracic Society. Dr. Kotloff is the recipient of the American College of Chest Physicians College Medalist Award, recognizing meritorious service in furthering work in chest medicine. He is also the recipient of the American Thoracic Society Outstanding Educator Award, which recognizes lifetime contributions in education and mentoring in the fields of pulmonary critical care or sleep medicine. It's great that he's here now to help us learn and to educate us. So I'm going to turn this over to you, Dr. Kotloff, and we're all going to pay really good attention. It's all yours.
First, let me make sure that you can hear me. You're able to hear me okay?
Yes, we can hear you.
Okay. I wanted to thank all of you for taking time out to join me tonight. I wanted to thank the LAM Foundation for inviting me. And I have to say, if there's one advantage to the pandemic, and there are very few, it's that this is the first time I've ever given a lecture in my bare feet. So it's actually the start of a trend. I'm going to try this at next year's LAMposium. So let me see if I can share my screen with you. You'll tell me if my slides show up in just a second. Okay. My computer's asking me all these security questions first, so I apologize. Can you see my screen? This slide?
Not yet. So when what it was doing with me, the updates on Zoom, Dr. Kotloff, is when you click the window that you want to share, there's a little button on the right-hand side that says save.
One participant can share at a time. Advanced sharing options. Multiple participants can share.
So if you click the up arrow.
Oh, I see. Wait a minute. I clicked the wrong. Let's try this one.
Yeah.
How's that?
That is perfect. We're there.
You can see my
Nice.
first slide.
Yes.
Okay. So I was asked to talk to you about rapamycin, and I thought I would make this a bit interesting and tantalizing and challenge you that over the next 30 minutes, I'm going to connect the dots here. And we're going to see what fruit flies, Easter Island, and the Miles trial share in common. So my goal here, let's see, there we go, is to cover the following. The first thing I want to talk about is why rapamycin? How did that drug even come to be thought of as a treatment for LAM? This didn't just fall off the shelf into Frank McCormick's lap. This was something that really was based on experiments that had been done in the laboratory. So there was really a biological basis for why this drug was chosen as a potential treatment for LAM. And I'm going to go through some of those trials with you at the basic science level. Then we're going to talk about two clinical trials that really proved that rapamycin was in fact effective in treating LAM. I'm going to talk a little bit about not just the benefits of rapamycin, but some of the side effects that you may have heard about, and try to put them into context for you so you can understand that most of the side effects are in fact more of a nuisance than anything that is serious or life-threatening. And in fact, the drug has proven to be remarkably safe to administer. And then I'm going to conclude the talk by talking about some of the lingering questions that we are actively investigating that I've listed here, but I'll go into more detail as the talk progresses. So I want to start with where we were not that long ago, and I've taken these quotes from two of the major textbooks of pulmonary medicine. These are not the current editions, but one is an edition from 10 years ago, the other is an edition from 12 years ago. One of the pulmonary medicine texts, Murray and Nadell, we call it. If you go to the LAM chapter in 2010, it says there are no well-designed studies upon which to base therapeutic decisions in LAM, and there is no consensus regarding optimal treatment. That was only 10 years ago. If you go to the Fishman textbook, the other major textbook of pulmonary medicine, you're going to hear a similar message. And I quote, "Thus far, treatment regimens have been unsatisfactory." In fact, the only treatment back then was progesterone, which some or many of you may have actually been on in the past, and unfortunately was proven not to be effective. But that was basically it at that time. Let me show you the remarkable progress that's been made by walking you through this timeline. And this is a timeline that you may have seen others present as well. I'm going to go way back to 1919, when we believe the first case of LAM was actually described in the medical literature. It took another 45 years before enough cases were assembled that someone published what's called a case series. So a case series means that it was a description of a handful of cases rather than just single case reports. So in 1966 was the first case series. That's how rare the disease was considered. Well, things started happening actually in 1994, and these should be two familiar faces to you. This is Sue Burns and Andrea Burns, her daughter. And you probably have heard the story, but Andrea presented in the early 1990s with unexplained pneumothoraces, was ultimately diagnosed with LAM, but was actually told, and Sue was informed as well, that we knew very little about the disease, and in fact, there was no treatment for the disease. And at that point in time, it was also considered a potentially lethal disorder. That was the news that Sue and her daughter had to hear, and Sue, in her motherly way, refused to accept that. And what she did in 1994 was she met Frank McCormick, who was at University of Cincinnati, still is there. And he not only assumed the medical care of Andrea, but Sue and Frank teamed up to create a grassroots initiative to start to learn more about this disease. And that's where things took off. So in 1995, the LAM Foundation was established. Sue lobbied Congress, got some money, and that led to a registry established at the NIH to track patients who had LAM so we could understand more about the natural history. And then what you can see beyond there, and we're going to talk about this, is some basic science discoveries, the gene responsible, the pathway that the gene was regulating, then 2 clinical studies in 2003 and the MILES trial starting in 2005. And then very shortly thereafter, the first effective drug, Rapamycin, and FDA approval coming in 2015. So first case described in 1919, but over the last 20 years, 15, 20 years, remarkable progress made in this disease and understanding the basic mechanisms and now having effective treatment. So I now want to focus your attention on some of the events that occurred in that timeline that I didn't necessarily show you on the previous slide, but that are vitally important to coming up with a therapeutic intervention. And this all has to do with a bunch of researchers who were interested in a disease called tuberous sclerosis, which is an inherited systemic disease, meaning it affects multiple organs. When it affects the lungs, it happens to cause a LAM-like illness. So we talk about TSC LAM, and we also talk about sporadic LAM, meaning LAM that is unassociated with TSC. But back in the early 1990s, a group of investigators who were interested in tuberous sclerosis complex identified a gene mutation that was responsible for the disease. In 1997, a second gene responsible for causing TSC was identified. But at that point, it was still a mystery why patients who had sporadic LAM developed their lung disease. We understood that in TSC, those patients who developed these cysts in the lung probably had to do with these genetic abnormalities. But why was it that patients who didn't have TSC would develop LAM? The major breakthrough came from a researcher whose name may be familiar to you as well, Lisa Henske, who at the time was in Philadelphia. And she was the first to discover that that same gene mutation that causes tuberous sclerosis was also present in the lungs of patients with sporadic LAM. So now we tied the two diseases together, but we still didn't know what the gene did. Why did a mutation in the gene cause LAM? Now we go to the fruit fly biologists, and what I'm showing you here in this picture is actually a fruit fly eye. Fruit flies have compound eyes. They consist of about 800 of these little orbs, these little spheres. And the advantage to using fruit flies is that diseases in a fruit fly will unfold over hours to days. They only live for a week or so. So things are accelerated. You can study a disease process over a couple days rather than having to wait a lifetime to discover it, to investigate it in a human. So what these biologists did was they found that fruit flies actually have TSC genes, and they mutated these TSC genes to inactivate them. So what I'm showing you here is a normal fruit fly eye. But now what I'm showing you on the right side of this slide is a mutant fruit fly where the TSC genes have been inactivated. So they're no longer working. And what happens, you can see what previously was a very well constructed eye now has all these bizarre giant orbs or spheres that represent abnormal growth. So instead of stopping their growth at a nice smooth sphere, they just kept growing and growing and growing, and you get this abnormal eye. So what they were able to show, let me show you schematically, was if we take a cell, let's say that's an eye cell, and we have functioning TSC genes, we're going to call those genes TSC1 and TSC2, that they keep the master switch in the cell that controls growth, they keep it in the off position. So these genes are responsible for preventing cells from growing in an abnormal fashion. However, if you mutate these genes so that they no longer work, that switch gets flipped on, and now you get unregulated growth and division of these cells, almost like a cancer. And in fact, some people have talked, as we'll get into, have compared LAM in certain ways to a very slowly evolving cancer. Okay? The next major advance in the field was figuring out what this switch was. So we knew that TSC1 and TSC2 genes kept the switch off, but what was that switch? And without going into too much detail, the discovery was that in the cell is a pathway or a switch that's called mTOR. And when mTOR is switched off, the cell is quiet, it doesn't divide. But when mTOR is switched on, that cell starts to divide. And if the switch stays on long term, those cells will continue to divide in an unregulated fashion. So now we know that TSC1 and TSC2 put a brake on mTOR, and that mTOR is the master switch. We also know, as I said, that when these genes don't work, that brake is taken off and the switch is turned on. Okay, so what does that mean in LAM when that mTOR switch is turned on? Well, what it means is you get this unregulated growth of cells, and when that happens in the bronchial tubes, all these cells, smooth muscle cells they're called, start to obstruct the bronchial tubes, and that's responsible for the difficulty in breathing and for the abnormal lung function studies when spirometry is checked in the laboratory. So we get what's called airflow obstruction. It takes a longer time for the lungs to empty of air, just like an asthmatic, for example, who also has obstructed airways. In the lymphatics of the lung, if they become clogged with smooth muscle cells, you get another manifestation of LAM called chylous effusions. These are these milky fluid collections in the chest, in the area around the lung. When the smooth muscle cells block blood vessels in the lung, patients with LAM, individuals with LAM can cough up small amounts of blood, and some of you may have experienced that. And then finally, outside the lung, when you get unregulated growth of cells in the kidney, you can get these benign fatty tumors called angiomyolipomas, and I'm going to show you an example of that. So now we've gone from the fruit fly to the human, and we see what happens when that switch is turned on in the lung and in the kidney. And I'm going to show you examples here. This is a typical CAT scan of a patient who has LAM, and many of you have seen this. These are the cysts or the holes that develop. Now, on the previous slide, I didn't mention holes at all, and that's been one of the mysteries. How does this unregulated cell growth lead to these holes in the lung? I'm going to go back to my diagram here, and I'm going to explain what our current theory is. So you have all these cells growing in unregulated fashion, and it ends up these cells actually release substances that degrade lung tissue. They're called MMPs. So they're releasing these enzymes into the lung, and what that does is create these holes or cysts. This is an example of what happens in the kidney for individuals who have heard about these AMLs or renal angiomyolipomas. Here's a kidney here. Here's another kidney here. And you can see these dark spots within the kidney. That's fat. That density is fat. You can see, if we look around the perimeter of this patient's body, you see the same density. This dark density is fat tissue. Here on the other kidney are the same types of things, and those are classic angiomyolipomas of the kidney. They are totally benign They're not malignant tumors, and they contain a large amount of fat. These AMLs can get quite large. This is one of my patients where almost the entire kidney has now been taken over by this fatty substance. You can see the same on this side as well. Okay, how does Easter Island fit into this? Well, that's actually where rapamycin was discovered. Rapamycin was an extract from a plant that grows on Easter Island. Easter Island is in the South Pacific, and the indigenous natives on Easter Island are known as Rapa Nui, and the island is also sometimes referred to by its native name, Rapa Nui. So when the plant extract was discovered on the island of Easter Island, they decided to call it rapamycin after Rapa Nui. It's also called sirolimus. You may have heard that as another name that it's referred to. And curiously, when it was first discovered, it was found to have antifungal properties. So it was felt to be something that could be given to patients who had fungal infections. It was subsequently found actually to have properties in terms of suppressing the immune system so effectively that the first FDA approval for rapamycin was not for LAM, was not as an antifungal drug, but was as an anti-rejection drug after transplant. And that still is one of its major FDA approved indications. It's used after kidney, liver, and sometimes after lung transplant. Like many drugs, however, it has other properties as well, and it was found that rapamycin also inhibits growth and division of cells, and serendipitously, it does so by turning that master switch off that I showed you in the previous slide, the mTOR switch. So rapamycin is an mTOR inhibitor. I showed you on the previous slides that LAM, whether it's TSC LAM or sporadic LAM, is a problem with where the mTOR switch is turned on. So what better drug to try than a drug that turns that switch off, that is a specific mTOR inhibitor? And that's what I'm showing you here. So again, if we think of LAM, we have a problem where the TSC genes are mutated and are no longer working. Because they're not working, the mTOR switch is turned on. Now we have rapamycin coming in as an mTOR inhibitor, and that turns the switch off, which is exactly what you want to do. You want to prevent further growth and division and proliferation of these abnormal smooth muscle cells. So it all makes sense in the test tube now, but the next step is to see whether it works in the patient. That led to 2 trials. Many of you are familiar with the Miles trial, but there actually was a trial that preceded that. The first trial was looking to see if rapamycin could shrink the size of angiomyolipomas of the kidney. Why was that chosen as the first trial? Why not start out and test its effect on the lung? Because this was actually an easier way to prove whether the drug worked or not, because you could image the kidney before you start treatment, and with an MRI or a CT, you can actually measure the size of these AMLs. Then you can treat, re-image, and remeasure the AMLs. So it's an easy and quick way to see whether rapamycin has an effect on one of the manifestations of LAM, not the one we care most about. We care more about the lungs, but this is just sort of a proof of concept. And what you can see, I'm going to show you this in 2 ways. So this trial enrolled patients who had LAM and renal AMLs, these fatty tumors, put them on sirolimus or rapamycin for a year, and then took them off and observed them for the next year. And if we look first at this MRI, I'm going to show you where the kidneys are. So here's one kidney, and you can see these fatty tumors. There's one, there's another. Here's the other kidney, which is quite large. It's about 3 times the size of a normal kidney, and you can see a lot of these fatty tumors in it. This is before the patient was treated. 12 months after the patient is on rapamycin, if you look at this kidney, you don't see any fatty tumors, all gone. And if you look at this kidney, it's shrunken in size dramatically. It is still a little bit enlarged, but not dramatically so. And there's only one remaining small AML. So visually, you can see that rapamycin had a dramatic effect on shrinking these AMLs. if you look at the graph, what we're looking at here is the size of the AML for each patient. So they basically imaged the patient and then measured the size. And then they plotted that size at 6 months and 12 months. And each of these lines represents an individual patient. And you can see for every patient where they started out here, by the end of the year, all these lines are pointing downward, meaning the size of the AMLs decreased in all the patients. What you then see is that for the next 12 months, when they stop the drug, the lines go up again. And what that told us was that rapamycin only had its beneficial effect during the time that the patient was taking the drug. Once the drug was stopped, the AMLs grew back. So now it was time for the more important question to be tested, and that was, did rapamycin have a beneficial effect on lung function? That's really what we're most concerned about in LAM, because that is the major issue in terms of causing symptoms and potentially causing life-threatening disease. So let me go through the MILES trial with you. You've heard that Sally was in fact volunteer number 1. I didn't know that about Sally before. I knew she was a diehard Cavaliers fan, but I never knew she was subject number 1, and I certainly appreciate her her courage in doing that and in contributing to the science of LAM. So what this trial did was it took about 90 patients and split them into 2 groups. So you may have heard, and you're hearing this with COVID now, that a properly designed trial is what we call a randomized, prospective, placebo-controlled trial, meaning that you split the group into 2. One group gets the drug that you're interested in, the other group gets placebo, and the patients don't know which drug they're getting until the code is broken at the end of the study. So we're going to look at 2 lines here. This line with the green dot, the green boxes, represents lung function in the group that received rapamycin or sirolimus. This line represents lung function in the group that received placebo. And there were 2 periods in this study. There was an initial 12 months where the treat group got rapamycin. And then there was a second period, a year later, where the group that had received rapamycin was taken off. So neither group in this second year received any treatment. And what you can see in the first year, very importantly, we're looking at something called FEV1, which is one of the lung function tests when you do spirometry, when you blow into that tube and we measure lung function. This is one of the numbers that we generate, and this is the number that tends to go down in patients with LAM as their airways become more obstructed. And you can see in the placebo group, here's where they started, here's where they ended. They ended their lung function at a lower level than they started with. So they experienced, on average, deterioration in lung function over that 1-year period. If we look at the treatment group, they actually experienced a little bit of an upward bump initially when they were treated. And then by the end of the year, they were at about the same level where they were at the start. So the bottom line is that they had stable lung function over the course of the year when treated, but declining lung function over the course of the year when not. So this was definitive proof that giving patients with LAM rapamycin stabilized lung function and prevented decline. There was a second important observation, and that has to do with the second year when the patients were taken off of drug. So neither group is now receiving the drug, and you can see that the patients who had gotten rapamycin now experience decline in lung function over that second year when the drug is taken away. So similar to what we saw with regrowth of those AMLs when the drug was taken away, same lesson here, that rapamycin seems to work while it's being administered, but that effect rapidly wanes once you take the drug away. This was a critically important study. You can imagine it was a very hard study to enroll patients. It was even harder because rapamycin was actually available. I told you it was available as an anti-rejection drug. So there were patients who were able to get the drug even independent of the trial, and that gave them less of an incentive to participate in the trial. So it took a while to get this trial conducted, but ultimately it proved that rapamycin worked, and ultimately it was the evidence that the FDA needed to approve the drug as an indication for treating LAM. So what have we learned about rapamycin since we've now have relatively extensive experience with it? In terms of benefits, I showed you that it stabilizes lung function. I showed you on a previous slide that it shrinks kidney AMLs. But other things we've learned is that patients who have chylous pleural effusions, these collections of fluid around the lung, that even low doses of rapamycin will will lead to dramatic resolution of those fluid collections. There are occasional patients with LAM who have what's called abdominal lymphangiomyomas, which are these sort of cysts filled with fluid in the abdomen. And again, low doses of rapamycin will cause those to resolve. And for women who have TSC LAM, they often have a rash on the face that can sometimes be quite apparent and sometimes disfiguring. And we've learned that a rapamycin topical solution just placed on the face will lead to resolution of or improvement in these facial angiofibromas. And for women who have TSC LAM and have these brain lesions called giant cell astrocytomas, that giving rapamycin will shrink those down. So dramatic improvement, not just in lung function, but in multiple other manifestations of LAM and in TSC. Well, how about side effects? There was a lot of concern about giving rapamycin, especially since I told you that we knew it dampened the immune system, and weren't we going to see all sorts of side effects? Well, we do see some common side effects that are, I would consider, more of a nuisance than anything else, and they usually don't lead to discontinuation of the drug. Mouth ulcers that come and go are relatively common. They can be painful and they are a nuisance, but fortunately for most patients, they're infrequent, or many patients don't experience them at all. Elevated cholesterol is almost universal. So no matter how fastidious you are with your diet, rapamycin elevates cholesterol levels, and for some individuals that means starting them on a statin or a cholesterol medicine to reduce the cholesterol. It can cause an acne-like rash on the face or chest, and it can cause swelling in the ankles. These are common side effects. A couple other things that we've come to experience, we've learned through experience. This is actually taken from the MILES trial. You can see in blue are patients who got rapamycin. In red are the placebo patients, and we're looking at what percentage of patients experienced irregular or absent periods or menses. You can see much more common in the group that was treated with Rapa than in the control group. So we now know that to expect infrequent or irregular periods or absent periods in patients on rapamycin. We've learned a similar lesson about ovarian cysts, that they are more common in individuals treated with rapamycin than in those not treated. But again, in most cases, it does not cause significant problems. I do want to comment on two of the more serious side effects. One is what I would call delayed wound healing. So I told you that rapamycin prevents cells from dividing. The benefit is it prevents the smooth muscle cells that cause LAM from dividing, but the disadvantage is that if you have surgery and now you need cells to heal that wound, it's preventing those cells from dividing and therefore potentially preventing wound healing of critical surgical incisions. Because of that, we not only strongly advise, we tell patients that they have to come off of rapamycin preceding any major surgical procedure, and then it can't be restarted until there has been adequate wound healing. And I'm going to show you one lesson that we learned in lung transplant. What I've shown you on this schematic here is a very critical surgical incision that has to heal, which is the connection of the bronchial tube from the donor lung to the bronchial tube of the recipient. That's sewn in here. And when we were using rapamycin early on in transplant as an anti-rejection drug, there were a number of cases where that wound just fell apart. And you can imagine that if the bronchial tube falls apart, that can be a lethal event. a fatal event. And because of that, there is now a black box warning on rapamycin that specifically states that the drug is not to be used in the perioperative period after lung transplant. That has created a little bit of a dilemma, because what do we do about patients with LAM who are on a waiting list for lung transplant? Do we stop the rapamycin? That's actually what we were commonly doing, but then the danger is that while they're waiting for their transplant, their LAM can accelerate and they may not make it to transplant. So that didn't seem like such a good idea. We can continue the rapamycin and then just stop it at the time of transplant. And many centers are starting to do that and have done it successfully without having this lethal complication that I mentioned. Or some centers are now recommending switching to a cousin of rapamycin called everolimus, which has the advantage of hanging around in your system for a much shorter period of time. So if you stop it at the time of transplant, it's gone within a day, as opposed to rapamycin, which can take 5 to 7 days to fully wash out of your system after a transplant. So the bottom line is more and more programs are allowing patients to remain on the mTOR inhibitors, some to stay on the rapamycin, other programs prefer switching to this other mTOR inhibitor. The other serious side effect you may have heard about is called pneumonitis, and this is a CAT scan where you can see these white areas. The black areas are normal, these white areas are abnormal. These are areas of inflammation, and we do know that rapamycin can cause inflammation of the lung. It presents as fever, cough, shortness of breath. It goes away if you stop the drug. Sometimes it requires prednisone to fully go away, and it's a reason that you contact your physician if you are experiencing prolonged fevers, cough, and shortness of breath. Fortunately, it's exceedingly rare. The last concern we had gets back to what I said before, that the drug is immunosuppressive. It's used to prevent rejection after organ transplant. And the concern was, well, if we immunosuppress women with LAM, aren't they just going to get infection after infection after infection? We also are concerned about certain cancers that can develop in immunosuppressed patients, particularly lymphoma. And you're going to see in the enclosure, if you open up the drug insert that comes with rapamycin, you'll see this quote: increased susceptibility to infection and development of lymphoma may result from immunosuppression. Fortunately, in the MILES trial and in our subsequent experience, there has been no difference in infection rates between the treatment and the placebo groups. We're not seeing a big uptick in infections in patients treated with rapamycin, and we're certainly not seeing any significant incidence of lymphoma or other malignancies. Just a quick point that you may have been cautioned about, those who are on rapamycin. There are a lot of drug interactions. There are a lot of commonly prescribed drugs that will dramatically escalate rapamycin levels and could lead to toxic effects. And there are some drugs that actually lower rapamycin levels and can prevent the beneficial effects. And then one thing that curious that you need to be aware of is grapefruit juice. Grapefruit juice actually strongly inhibits the metabolism of rapamycin by the liver, and therefore can dramatically increase rapamycin levels and cause toxicity. So we instruct patients on rapamycin that they need to avoid grapefruit juice. Other citrus drinks are fine. Grapefruit juice, absolutely not. So just to summarize what I've said so far, despite its many potential side effects, rapamycin is generally well tolerated. We are actually starting to use lower and lower doses than were even used in the MILES trial, so we're seeing less in the way of side effects. Rapa does require monitoring of certain blood tests, so you will be asked to have a blood level of rapamycin measured, your cholesterol measured, and we also measure CBCs or complete blood counts. Typically, we do that at 3 to 4 month intervals. I just wanted to ask you, it's 7:45. I do have a couple more slides, so I can either keep going a little bit or stop. Let me ask you what you'd like me to do there.
You're good. Please continue. This is really wonderful.
Okay.
Thank you.
So now we're going to get into a little bit more complicated slides, but they address some unanswered questions. So I'm going to try to walk you through these. One question we have is, can we use VEGF-D levels? You probably recall that VEGF-D is a blood test that the levels are elevated in about half to 2/3 of women with LAM. We actually use it as a diagnostic test. So if a patient presents with cysts in the lung, one of the ways we can prove definitively that it's LAM is we can send a VEGF level off, and if it's above 600 and in particular above 800, that is by definition diagnostic of LAM. So the question is, can we also use VEGF blood levels to predict who needs to be on rapamycin and how they're going to respond? So let me walk you through these two graphs. This is actually taken from analyzing the data from the MILES trial. And we're going to look first at women who had high VEGF levels. So they had VEGF levels greater than 600. We're going to look at 4 time points, 3 months after starting, 6 months, 9 months, and 12 months. This is the group that got rapamycin in the MILES trial. This is the group that received placebo. If you're below the line, that means your lung function declined. If you're above the line, that means your lung function improved. So let's start with the placebo group. If you have a high VEGF level and you don't get treated, that seems to predict a high likelihood that you are going to experience decline in lung function. So another way to say that is maybe we can use VEGF-D levels, and if we see a high level, that might be someone who we're more aggressive in wanting to treat. But we clearly see that it portends a high likelihood of decline. Now, on the other hand, if you have a high VEGF level and you're treated, there's a significant uptick and a significant improvement in lung function and then stabilization. So decline without treatment, improvement and stabilization with. Now we get into a more problematic group, which is if your VEGF level is normal, if you're not treated, which is the blue line, there really wasn't much change over the course of the year. So unlike this group with a high VEGF level where they declined, the group with a low VEGF level stayed around 0, meaning no change high or low. And if you were treated with rapamycin, the same was true. There wasn't really much of an effect. So what can we take from this? Well, if this pans out with further study, it would mean that we actually might want to specifically target patients who have high VEGF levels as those most vulnerable to decline without treatment and most likely to respond with treatment. In contrast, patients who have normal VEGF levels, we may want to watch them and see how their lung function behaves rather than rushing right in and treating. This is not carved in stone yet. This is all just preliminary observations. Here's another observation, and this is a little bit more of a complicated slide, so let me walk you through it again. This is also taken from the MILES trial. This is the placebo group in this graph. This is the treated group in this graph. And what are we showing here? Each of these bars represents an individual patient. If the bar goes up, it means that lung function improved in that patient. If the bar goes down, it means that lung function declined over the course of the year in that patient. And how long that bar is tells you the magnitude of effect. So the higher the bar in the positive range, the more improvement. The higher the bar in the negative range, the greater the decline. And you can see in the placebo group, as we saw in the other graphs, that virtually all the patients experienced decline in lung function over the course of the year. Okay, very few had this little uptick, spontaneous uptick in lung function. Now, more importantly, let's look at the group that was treated. The first thing you notice is that a significant proportion of those patients improved. So unlike the placebo group where there were only a few patients that improved, half of the patients who were treated with rapamycin showed improvement in lung function over the course of the year. And then there was another handful where they had very little, they had a little bit of a downtick, but very little. They were still pretty much unchanged. And then there were some patients who were treated but did not respond. Now, what do the green versus the red bars mean here? And this is where it gets a little complicated. So if you were a patient designated by a green bar, that meant that your VEGF level at the end of 1 year on rapamycin decreased by more than 40%. So what do I mean by that? I'll give a concrete example. It went from a VEGF level of 1,000 to a VEGF level of 600. That would be a 40% change. So if you had if your VEGF-D level decreased significantly in response to rapamycin, you were much more likely to be in the group that realized improvement in lung function. See all the green bars here? On the other hand, if your VEGF level didn't change very much on rapamycin, you were much more likely not to respond to the rapamycin. You can see that the non-responders, there's a lot of these red bars here. There are a few green bars, but mostly red here, mostly green here. So let me just summarize, because that was a lot of confusing graphs, and let me summarize what this, I think, potentially tells us. So can we use VEGF-D levels to predict response to rapamycin? What we can say is that individuals with high levels seem to be most likely to decline without treatment and improve with treatment. Individuals whose VEGF-D levels fall dramatically on treatment are more likely to see improvement in lung function. So it still raises the unanswered question that we are continuing to explore of should we use these levels, these VEGF-D levels, to determine who to treat and how to adjust the dose of rapamycin. So for example, should we continue to increase the dose of rapamycin until we see the VEGF-D level fall by more than 40%? Is that how we should dose it rather than by blood level? I'm going to real quickly go through some of the other lingering questions. Another one that's currently being studied is should rapamycin be given earlier in the course of the disease? So right now, the non-controversial indication for giving rapamycin is an FEV1, this one lung test parameter, less than 70% of normal. That's taken directly from the MILES trial. To get into that MILES trial, your lung function had to be less than 70%. So there's no question that any LAM physician will give a patient rapamycin if their lung function is below 70%. Many of us will also give rapamycin to patients who are above 70%, but are showing that year after year they're losing lung function. So why wait until they hit the 70%? Let's treat them earlier. But even more controversial is, how about patients who have relatively normal lung function? Maybe we should be starting those patients on low-dose rapamycin so they never lose lung function. And that's a trial you may have heard about called the MILD trial that is currently enrolling. It's enrolling patients whose lung function is above 70%, but have mild evidence of impairment. And I'm not going to go over all the details here, but these are the ways that we would demonstrate mild impairment. And it's putting these patients on very low dose rapamycin, just 1 milligram a day, and randomizing between treated patients and placebo to see whether we can prevent decline earlier in the course of the disease before patients lose significant amounts of lung function. So unanswered question, hopefully answered with the MILD trial, with results coming in the next several years. Last point, because I get asked this a lot or did in the past, a lot of patients have heard about combining rapamycin with a statin called Simvastatin. I don't know where there we go. Simvastatin is a cholesterol lowering drug, but it also happens to have some other effects. It inhibits smooth muscle cell growth, and it inhibits release of these enzymes that I mentioned that cause cysts. So boy, that sounds like another ideal drug to try in LAM. And again, a complicated slide that I'm going to make easier for you here. This was a study in mice. You may know that there is actually a mouse model of LAM, so that's the perfect model to use to test drugs. And what was shown, I'm going to simplify this graph by saying that the taller the bar, the more cysts that the mouse had. And then we're showing you 4 treatment groups. In the first group with the tallest bar, these mice were given nothing, no rapamycin, no simvastatin. The second group got rapamycin, no simvastatin. Third group got simvastatin, no rapa. And the fourth group got both. And you can see, I'm going to show you schematically here, that if the mice received no treatment or they got rapa alone, they all developed cysts. But curiously, if they got simvastatin or simvastatin in combination with rapa, you can see these bars are lower, meaning that it prevented the development of large cysts. So boy, this would be great. This would be a home run if we could somehow prevent that destructive process in the lungs. And where are we with that? Well, we just completed the SOS trial that was published. That was simply a trial to make sure that it's safe to give rapamycin and simvastatin together. It was 10 patients. It was proven to be safe and well tolerated to give both drugs together. But there actually was a somewhat worrisome signal that suggested that the FEV1, the lung function, actually declined faster than those who were treated with simvastatin rather than what would have been predicted with just getting Rapa alone. This is only 10 patients, so can't draw any conclusions yet. But all we know about the combination of Rapa and simvastatin at this point is that it's safe to give in terms of side effects. We don't yet know whether it's beneficial in terms of preserving lung function. Last question that we don't have an answer to is, are the effects of rapamycin durable? Do they last for years? And is it safe? The LAM Foundation has created what's called the MIDAS registry. Many of you have been asked to participate, and that simply means that your information every time you visit the doctor is being entered into a registry so that we can follow patients long-term and see if they maintain their lung function benefit, and also to make sure that giving this drug over many years is actually a safe thing to do. So we don't have answers to this yet, but the MIDAS registry will provide that for us. So I'm going to conclude here, and I apologize for running over a little bit. Just take-home points. Identification of rapamycin as an effective treatment for LAM was a culmination of work by many dedicated scientists and clinicians. And I also want to give a shout out to the sacrifices of many fruit flies and mice. Despite the potential for many side effects, rapamycin is generally well tolerated. Commonly used drugs can alter rapamycin levels, so it's very important to talk to your LAM doctor if anyone wants to prescribe even a common antibiotic, just to make sure there's no interactions. And then I talked about 4 lingering questions: whether we should be using VEGF-D levels to predict who to treat and how much to give. What's the long-term benefit and safety of giving rapamycin? The MILES trial was only 1 year long in terms of giving it. When should we initiate treatment? Should we wait until the FEV1 is 70%, or should we give it when there's the first signal of declining lung function? And is there a role for combination therapy with simvastatin or other drugs that are in the pipeline as well? So I'm going to stop there, and I'm very happy to answer any questions that you might have. I think I'll stop sharing my screen there. Is anybody still awake?
Can you hear me now?
There we are. We're just muted.
Okay, good. Now I'm unmuted.
Are you there,
That
Maddie?
was excellent, thank you. I just wanted to ask if it's been recorded so that more people in Australia get the benefit of listening.
Yes, I'll go ahead and answer that. And yes, the video or the recording, the presentation is being recorded, and it should be up on our website within a week. You can check back to the LAM Foundation, to the website, and then you'll find the LAMposium in your living room landing page there. And we usually put that out on social media and in an email as well. So,
Many thanks.
Can you enable chat function so we can ask questions?
yes, what we're going to do actually, just to eliminate some of the background noise, is, if you would, Karen, was that you, Karen Kinsey?
Yes.
Yes, is we'll go ahead and have you type your question, if you can, into the chat box. And so anyone can do that. Does everyone know where to find the chat box? And then Madeline, are you ready to go with questions, and we'll read from there?
Okay, yeah, sure. All right, I didn't know if Sue was speaking now or later.
Yeah, that was my bad. Yeah.
Okay, so we're good here. I have a couple questions that were sent in ahead of time. So Dr. Kotloff, I'm going to read one to you. This question says, I'm 50 years old with a constant FEV of 80%, FEV1 of 80%. I'm unsure if this disease stops progressing.
I know that.
I'm unsure if this disease stops progressing greatly at this age or at menopause, or if I should consider rapamycin for prevention to slow the progression. Basically, I am living a normal life, although everything is reduced in exercise. And I do have great concerns about progression. Thank you for asking for our questions.
So I actually hear 2 points raised in that question.
Okay.
One has to do with, is there a point in time when progression is less likely? And second is, are there indications for starting rapamycin or sirolimus earlier in the course of disease when FEV1 is still 80%, which is still in the normal range? So to answer the first question, we clearly now know that menopause is an important milestone in the natural history of LAM, in that the likelihood of progression and the rate of decline decrease after menopause. So for women who have maintained normal lung function and are postmenopausal, the likelihood that they're going to have significant decline in the postmenopausal period is relatively small. So the first part of your question, if you're 50 and perimenopausal or postmenopausal, yes, the likelihood of the disease progressing is far less. The second part to your question is, should you consider rapamycin when your FEV1 is 80%? And I would say that in general, the answer to that would be no. The only reason to consider it would be if there is a clear-cut trend such that every year there has been a significant decline. So yes, you're at 80% now, but maybe you were at 100% 5 years ago, and each year you're losing significant lung function. So if we see a trend, a clear-cut downward trend, we might be willing to give rapamycin earlier. But if your disease is truly stable at 80%, there would be no indication for giving the drug at this point.
Okay, thank you. That was great. Now we have another question. And this one comes from Sandra. She writes, I have been diagnosed with LAM for 2.5 years at age 70. I had a nephrectomy at age 22 for an angiomyolipoma. So have undiagnosed LAM for 48 years. My question is, should I be on medicine to prevent its progress since I have fared so well? My only symptoms has been dyspnea. I could say that again, but I won't.
Dyspnea.
On exertion. And 70% relieved with albuterol inhaler. And for the past year, a productive cough with clear mucus.
So
She's already 70 and wondering, what do I do now?
So the first point to make is that clearly the disease started many years ago, because angiomyolipoma of the kidney was likely the first manifestation that you had LAM. The fact that you've had it for so long suggests that you have a relatively mild form of the disease. What I didn't hear is what your current lung function is, and that might enter into a decision as to whether to treat or not. So the best way I could answer this is I'd want to get breathing studies. If your lung function is relatively well preserved and it's been stable, there would be no reason to consider treating with rapamycin at this point. On the other hand, if it were below 70% certainly, or if it was showing signs of deterioration on an annual basis, then your age alone would not be a reason to not administer the drug if we needed to.
All right, thank you. Now we have a few other questions, and of course, I lost where I want to be. There we go, back to the chat. I'm sorry. All right, so there's quite a few questions, and I'll start at the top, and we'll see what we can go through. Okay, so this is from Allison. For those of us with lymphatic LAM, which results in chylous effusions, masses that cause pain, etc. We already know that Rapa is very effective in treating this type of LAM, as you mentioned. But are there any new developments in the understanding of lymphatic LAM? Any new research? For example, what is the mechanism by which Rapa stops a chylous effusion? Why some of us get lymphatic and some don't? And this is from a person who does have sporadic lymphatic only.
Okay.
sporadic LAM only, with no lung cysts.
So the answer to your question is, I don't know the answer to your question. It's a good one, and we certainly know that there are some patients who present predominantly with lymphatic manifestations, and you've identified 2 of the 3 that would define that. One is the chylous effusions, the collection of lymph fluid around the lungs. The second are what I had mentioned previously called lymphangiomyomas, which are these fluid-filled sacs that can develop typically in the abdomen, that can at times be painful. And then the third that you didn't mention is actually the rarest form of lymphatic LAM, which is called chylous congestion. So there are some patients where this chylous fluid, this milky fluid, actually starts to fill up the lungs themselves, not around the lungs, but in the lungs themselves. All 3 of these manifestations respond exquisitely to Rapa, so that's the good news. And the presumption is that for some reason in these types of individuals, the smooth muscles are tending to grow and clog up the lymphatics more than they're clogging up the bronchial tubes. Why that is, I can't tell you, and I'm not sure that anybody else could necessarily give you the answer to that at this point.
Thank you. All right, so now Lindsay has a question. Do we know Rapamycin's long-term effects on female reproductive system? Do we know if there's any safe amount of Rapamycin that a pregnant LAM patient can take? Anecdotally, I saw in the private LAMmies group on Facebook that a woman in Europe with LAM maintained 2 milligrams throughout her pregnancy and delivered a healthy baby.
So we don't have a lot of data on this. What we have is anecdotes, as Lindsay has referred to. The other place, and I might have to get back to you on this, where we've actually learned a lot about pregnancy and administering these drugs is actually a transplant registry. So there is a registry kept in Philadelphia actually that tracks women who have been organ transplant recipients who are on immunosuppressive drugs and then successfully have undergo pregnancy and delivery. And that has reported on the safety of these drugs and on any teratogenic effects on the fetus, on the baby. I don't know if there's enough experience with rapamycin in particular in that setting. So that's a long-winded way of saying that I don't have a specific answer, but I am aware of the same anecdotes that you're quoting of successful pregnancy in women who have been on rapamycin. The one concern, by the way, that you'd have to be careful about is with cesarean section, now you have a surgical incision that needs to heal. And I'd be somewhat concerned about maintaining the rapamycin until that incision had completely healed.
All right, complicated question that is. All right, now here's another one, something current. Is there any understanding of rapamycin and COVID-19?
Okay. It's curious that you bring that up because there's actually, I don't know how many of you recognize the name Nishant Gupta, who's basically taken over overseeing the LAM program from Frank McCormick. Nishant is a wonderful physician at University of Cincinnati, and he has been trying desperately to start a clinical trial using rapamycin as a therapy in patients with COVID-19. Now that sounds totally counterintuitive, because the more common question I get from LAM patients is, I'm on rapamycin, I'm immunosuppressed. Doesn't that mean that I am at greater risk of developing severe complications from COVID? When we think of being immunosuppressed, we think that you're going to be at greater risk for overwhelming infection. Well, if you've read anything about COVID, you probably know that for the more serious infections, there's 2 stages. There's a typical flu-like stage where you just feel miserable, fever, cough. And then after about 7 days, in a subset of patients, there's what's called a cytokine storm, which is the immune and inflammatory system of the body just escalating dramatically. And instead of being beneficial in fighting the virus, now being destructive and causing a number of serious consequences of COVID. So to treat that, we actually are giving immunosuppressive drugs. You may have read that we now give steroids, dexamethasone, to patients who are on ventilators with COVID to try to mitigate or attenuate this cytokine storm. So Nishan is interested in the same philosophy. Well, what if we give rapamycin, which is also an immunosuppressive drug? Maybe we can blunt that cytokine storm and actually prevent serious consequences of COVID. So the bottom line is, half of me says that rapamycin makes me nervous because maybe patients are more predisposed to serious complications of COVID because they're immunosuppressed. And the other half of me says, well, maybe it's actually beneficial because it could prevent that cytokine storm. And the bottom line is, no one knows at this point. If Nishan has his way, there will be a clinical trial looking at giving rapamycin, not to LAM patients, but to patients infected with COVID in the intensive care unit.
Okay, more info to come on that. All right, next question is, well, actually, this isn't a question, but a former patient of yours wants to make sure she says hello, and that's Joyce Dillon.
Oh, one of my favorites, although all my patients are my favorites. But yes, Joyce, how are you? I hope you're doing well.
Madeline, you missed my question.
I did. Oh boy, I'm in trouble now.
Karen's,
Are we talking about Karen?
Yeah.
Okay, Karen. Is Simvastatin the only statin that reduces smooth muscle and MMPs?
The answer is that if you talk to Vera Kromskaya, who is the basic scientist who I showed you that mouse model and the graph, that's her trial. She actually looked at a number of statins, and Simvastatin was the only one that demonstrated this beneficial effect. That's been a controversial statement, and other researchers have challenged Vera on this, but if you talk to her, she would tell you that it's the only statin that she's been able to show decreases cyst number and size in mice. And that's why she chose to test that as the first statin in humans.
Okay. All right. So now we're moving on to Nicole. I am not on Rapa, but take Simvastatin for my cholesterol. Should I switch to Simvastatin?
I'll start with the snarky answer that I give to my patients, which is if you're a mouse, I would suggest you make the switch because we know that it's effective in mice. But the reality is that in humans, we just don't know yet. So I have a lot of patients in the past who have asked me, should they start a statin because of what they were hearing at LAMposium? And more specifically, if they're already on a statin, should they switch to Simvastatin? And the answer is we don't know yet. All we know about Simvastatin is that in the 10 patients that were given it in this phase 1 trial, it was safe to give concurrent with rapamycin. What we don't know in humans is whether there's added benefit above and beyond giving rapamycin. That is for the next trial.
All right. Now,
So Madeline, this is Shar. I'm going to interject for just a moment. Dr. Kotloff, I want to check on your time. It's 8:15 for you, if I have that right. Yes. Are we good for a couple more questions or?
I'm okay. I don't want to take up your time if I'm belaboring things here. So I'll leave it up to you and the group.
Yeah, show of hands. Should we let the continues keep coming? The questions continue? I think it's going to be pretty unanimous. Yes. Okay. If you're good. We'll and thank you very much, Dr. Kotloff.
all right. So now we have Corinne from Australia. For patients in Australia, how do we find out if we can participate in U.S. trials? Age 43, mild LAM, diagnosed in 2018, and currently not on medication.
I actually don't know the answer to whether so I know that mild, for example, the trial that is looking at earlier intervention with rapamycin, because it has been challenging to enroll patients, there are now sites outside of the United States that are enrolling. I don't know if there's a site in Australia or not. And that's something that the LAM Foundation would be able to provide information for you on.
Yep, Corinne, that's a great question, and I'll be in touch with you after the session tonight. So thank you. Yeah.
All right, moving on. This is from Inez. And she says, what about the use of Rapa when a Lammy has a really low FEV1? I never know what to say to other Lammies about that. Many Lammies with low FEV are told not to take it and just wait for transplant.
I personally don't see a downside to taking the drug while waiting for transplant. I certainly don't think they're mutually exclusive. I did mention the controversy about being on rapamycin, but most transplant programs, most experienced programs now are allowing patients to stay on rapamycin while they're waiting for transplant. And while we don't know whether the effects are as good in someone with an FEV1 of 20% as they are in someone with an FEV1 of 70%, on the flip side, I have no reason to believe that they're not as effective in stabilizing disease. So whatever you can do to stabilize lung function while waiting for transplant, I think is beneficial. And I strongly advocate being on the drug.
I meant for someone who never took rapamycin.
Someone who was never on rapamycin and is now on a transplant list?
Yeah, they never gave rapamycin just because it was really low, the lung function.
So again, in that case, the purpose of the drug is not going to be to prevent the need for transplant. It sounds like that's already been established. The purpose of the drug would be to try to stabilize lung function to allow that patient to wait safely on a lung transplant list. You may know, at least in the United States with the LAS system, the allocation system, that LAM patients are afforded relatively low priority. I won't get into all the issues as to why. It's not necessarily that the system is unfair, but because the priority score that LAM patients are given is generally relatively low, the waiting times can be a year or longer. So my rationale for giving that individual rapamycin would be to try to keep their lung function stable during the prolonged period that they're waiting for transplant. I'm not sure you'll get the same answer from everyone, but that's my approach.
Just to add a personal note, I was on rapamycin up until I got the call for my transplant.
Okay.
My center thought it was just fine to keep taking it. All right, so a couple more questions. Any precautions that we need to be taken with COVID as LAM patients? Anything extra?
No, the answer is the things that you've heard over and over again from Tony Fauci and others, which is masking, mask, please wear masks, social distancing, hand washing, and in general, limiting the number of contacts that come into your household to other individuals who have been as careful as you, and really limiting that number in general. So it's the same precautions that we tell everybody, but it's also the recognition that if you have abnormal lung function and you get COVID, you are at greater risk of having complications. So you have to be that much more cautious.
All right, and I'm having trouble reading another message here, but I'll skip it and maybe it'll be clear once I get to the one below it. All right, so once you're on Rapa, how long should you check Rapa and trough level, and how often? Every 3 months, in the first year, after the first year, and besides Simvastatin, what other cholesterol? Well, we already talked about that.
So the issue of checking rapamycin levels has become a bit controversial, as everything else. The traditional approach has been to check it every 3 to 4 months and to aim for levels in the bloodstream. We used to say 8 to 12. Now most of us are aiming more for a level of 4 to 6, but checking 3 to 4 times a year. I can tell you that I spoke to Frank McCormick recently, and maybe others can vouch for it who he cares for, but he basically starts everybody on 1 milligram of rapamycin, at least at the start, and doesn't even, after an initial check of level, doesn't continuously check those levels. So some people are getting away from checking levels and just using a standard dose. But the conventional approach would be to check that along with cholesterol. We check liver function studies because occasionally Rapa can inflame the liver. That's a relatively rare complication. And we check complete blood counts because Rapa can sometimes cause anemia, and typically that's at 3 to 4 month intervals.
Thank you.
And in terms of statin, I think I answered that
Yes.
right now the focus has been on Simvastatin based on Vera-Krumskaya's research.
Do we know if Rapa can aid in preventing collapsed lungs?
That's a very interesting question. There are anecdotal reports that patients who have had frequent pneumothoraces who are placed on Rapa, that the frequency or incidence of their pneumothorax declines. I just had a conversation with a LAM director up in Boston who swears that it's effective. You're not going to find evidence of that in the literature yet. It's all anecdotal, and I can't speak personally to that effect, but there is some suggestion that it may decrease the frequency of pneumothorax.
All right. Let's see. Should people have their VEGF-D test done if they've never had one yet?
Also an interesting question. I'd say that right now, VEGF-D is principally used for diagnosis. So if you have an established diagnosis of LAM, you don't need the VEGF-D level, obviously, to confirm it. Where this would get a little controversial is if there's a question of whether you should go on rapamycin and you're sort of on the fence, then documenting a high VEGF-D level might be enough to tip you over to starting the drug because you're going to be at greater risk for decline in lung function than someone who has a normal VEGF-D level. So that might be one reason to consider it. A second reason to consider it would be someone who's on rapamycin, but who is experiencing continued decline in lung function. I would want to check a VEGF-D level to make sure that it's low. If it's still high, then I would increase the dose of rapamycin until that VEGF-D level comes down to normal. Again, a little bit controversial, but I've shown you the evidence that seems to support that approach.
Another one about children. Is Rapa use all right to do during breastfeeding?
That's a good question, one that I'm embarrassed to say I don't know the answer to. So that's one, if you want to send me your email address, I can email you an answer, but I don't want to advise you incorrectly on that.
Good answer. All right. Let's see.
Maddie, I'm going to jump
Have you
ahead
done
on
it?
one, and I think we'll go ahead and wrap up with maybe just a couple of more here so that we
Yeah.
have time to
Sure.
free up our speaker and move into the discussion. But one question, this is coming from Vanessa. If lung function is within normal range, is there a downside to participating in the mild trial?
So if your lung function is absolutely normal and you don't meet any criteria for participating in the mild trial, then you would not be allowed to participate. The argument there is if everything's perfectly normal, we don't want to subject you to even a small risk associated with side effects from Rapa. But if your lung function is normal, but you meet those more subtle criteria, then I would strongly encourage you to participate in the mild trial because it's essential that we get an adequate number of individuals participating. So please contact the LAM Foundation to see if you're an appropriate candidate, and if you're willing, it would be great if you would participate.
Well, there are a lot of thank yous coming in.
Oh,
And another one from one of your former patients, Helen Grice.
oh boy. Okay.
She's your favorite too, right?
Yes, another one of my favorites. I saw a lot of familiar faces there, and again, I want to thank everybody for allowing me to participate in your care and coming to LAMposium every year. And Sally Nagel, I see again a table mate of mine at LAMposium, so I'm looking forward to sitting next to you and talking about the Cavs losing season next year. But thank you to everybody for inviting me.
Yes.
I'm not a Cavs fan anymore.
No.
I gave up on them. They're not doing well.
Okay.
You might be
Yeah.
a Browns fan. I don't know yet. You might be
Yeah.
a Philly fan. Who knows? We'll see with this short season.
So, Dr. Kotloff, I want to read just one more here, just scrolling way down. This is from Holly. She says, thank you. This has been the best and most thorough explanation of LAM I have heard yet. So, and I think
My
that
pleasure.
sums it up. So, thank you to everyone who's been here tonight attending. We've had the representation from various countries is amazing. We have LAM investigators on this evening. We've had our clinic directors, nurses, patients, family members. So this is, I guess, one of those upsides of a virtual event, but I echo what Dr. Kotloff said earlier this evening. I'm eager to get back and see everyone in person as well. So Dr. Kotloff, thank you very much. We'll go ahead and let you on with your evening. And thank you. And we hope that the rest of you, please stay, and Madeline's going to transition us into a family and group discussion where we can just kind of share stories. And you take it, Maddie. I've said enough.